So next in the line is the median nerve. So guys, let's first talk about the course of the median nerve. You already saw how median nerve leaves the axilla and was running in the arm. If I just quickly repeat that for you, you saw that the formation of the median nerve was lateral to the brachial artery. It runs lateral to the brachial artery. In the middle of the arm, it crosses the brachial artery. It crosses the brachial artery from lateral to medial side, superficial to it, and then comes medial to the brachial artery in the cubital fossa. And in the cubital fossa, the most medial content was the median nerve itself. Now, we should discuss the median nerve from the elbow and beyond the elbow only, because median nerve is not supplying any muscle in the axilla, nor it is supplying any muscle in the arm. So the supply of the median nerve is to the muscles which are below the elbow only. The first muscle is like pronator teres and then so on. So if there is injury to median nerve in the at the elbow level or above the elbow region, the presentation of the patient will be exactly the same only. That's why what we need to understand about the median nerve is to see the course and the supply beyond the elbow. The root value for the median nerve, just like radial nerve, is the entire brachial plexus. So it is again coming from C5 to T1. It is from C5 to T1. And as I said, our discussion will start from the lower end of the humerus here. Let us say, if this here is the lower end of the humerus, the muscle forming a medial boundary of the cubital fossa, that was the pronator teres. If you remember the cubital fossa we discussed, I showed you the two heads of the pronator teres were there. One was the humeral head and one was the ulnar head. So guys, let us say this here is the humeral head of the pronator teres. We have a humeral head of the pronator teres muscle. You can call it superficial head also. And there's another head which will be coming from the ulna. And when I drawing like this is, let's say, the ulnar head. So all in all, the muscle is what? That is a pronator teres muscle. So median nerve, yes, it is a content of the cubital fossa, but it leaves the cubital fossa how? It leaves the cubital fossa by passing between the two heads of the pronator teres and then continue its journey in the anterior compartment of the forearm. It continues its journey in the anterior compartment of the forearm. Once it reaches the flexor retinaculum, now if this is the flexor retinaculum present at the carpal bone region, let me highlight that. If this is the flexor retinaculum, then the nerve will go further in the hand and will supply the thenar muscles mainly. We'll come to that. Let's go with the details one by one. So we said, first of all, the median nerve leaves the cubital fossa by passing between the two heads of pronator teres. That is one. Obviously, it supplies pronator teres also. Now, once the nerve comes out of the cubital fossa and is running in the anterior compartment of forearm, the thing is, median nerve is a dominant nerve to supply the muscles of the anterior compartment of forearm. Most of the muscles in the anterior compartment of forearm are supplied by median nerve, but this one single branch is not able to supply the superficial as well as the deep branch, deep muscles. So what will happen? This median nerve, the main median nerve, will continue its journey and will keep supplying the superficial muscles in the front of the forearm here, like flexor carpi radialis, flexor digitorum superficialis, pronator teres, and so on. The deeper muscles, which like flexor digitorum profundus is deep, pronator quadratus is deep, flexor pollicis longus is deep, those deep muscles are supplied by the median nerve only, but by the branch of median nerve which goes deeper, and that nerve is called as anterior interosseous nerve. Guys, posterior interosseous nerve was the continuation of the radial nerve, whereas anterior interosseous nerve is a branch of median nerve which goes deep and will take care of the deeper muscle. So this nerve is what? That is an anterior interosseous nerve. Though I hope there is no confusion in that, but just to repeat that, when we talk about anterior interosseous artery, posterior interosseous artery, both anterior and posterior interosseous arteries are the branches of common interosseous artery, and that common interosseous artery was coming from the ulnar artery, right? But when we talk about nerve, posterior interosseous nerve is the continuation of radial nerve, anterior interosseous nerve is a branch of median nerve. So this main median nerve, as I said, will take care of the superficial flexors. Now, what are the superficial flexors we are talking about? Like, one is pronator teres, that is done. Okay, pronator teres supplied. Then it must be supplying the muscle that is palmaris longus, flexor carpi radialis, It supplies flexor digitorum superficialis. So all these superficial flexors, palmaris longus, flexor carpi radialis, and flexor digitorum superficialis, out of which I would like you to highlight the FDS, flexor digitorum superficialis muscle, is an important one here. Whereas anterior interosseous nerve is the one which is going to supply the deep muscle. There are three deep muscles. We have flexor digitorum profundus, we got flexor pollicis longus, and then finally it also supplies the pronator quadratus muscle also. The three muscle, flexor digitorum profundus, flexor pollicis longus, and pronator quadratus. Out of which again I wanted to highlight the flexor digitorum profundus. But guys, what is to be noted that entire flexor digitorum profundus is not supplied by the median nerve. Flexor digitorum profundus muscle is a hybrid muscle. Only the lateral part of the muscle is supplied by the median nerve or the anterior interosseous nerve. So we are just talking about the lateral part or lateral half of this muscle. Lateral half is supplied by median nerve. Medial half will be by the ulnar nerve. We will see that in the next discussion. I hope this is clear. So we have a superficial muscles to be supplied by the main median nerve, and a deeper branch of median nerve called as anterior interosseous nerve is taking care of all the deep muscles of anterior compartment of forearm. Once the median nerve leaves the carpal tunnel, or it goes through this carpal tunnel deep to the flexor retinaculum, it enters in, and then this median nerve what is going to do is going to give a branch which slightly goes back, and that's why we call it a recurrent branch. I'm writing RB here. That is a recurrent branch. It goes slightly back. And this recurrent branch is going to supply the thenar muscles. This recurrent branch is going to supply the thenar muscles. You know, the median nerve is a major supply to the thenar muscles, except which one? Except the adductor pollicis. We discussed this already in the muscles of hand. Adductor pollicis was the muscle which was supplied by the ulnar nerve, deep branch of ulnar nerve. It's the other thenar muscles like flexor pollicis brevis, abductor pollicis brevis, opponens pollicis. All these are supplied by median nerve. Which branch of median nerve? We call it a recurrent branch of median nerve. Not only this, the median nerve is also taking care of the first two lumbricals, the unipinnate lumbricals. Let me write L1 and L2. The first two lumbricals are also supplied by the median nerve. Now comes a very important point here, guys. If you remember the relations of flexor retinaculum, see that's why the sequence of understanding this topic is important here, because whatever we discussed earlier, now those things will be taken in account. If you remember, when we talked about the relations of flexor retinaculum, we saw some palmar cutaneous branches are going superficial to retinaculum. Median nerve is going deep to the flexor retinaculum, fine, but the palmar branch or the palmar cutaneous branch is passing superficial to it like this. So this here is a palmar branch, or you can simply say palmar cutaneous branch. Same thing, palmar branch or palmar cutaneous branch. Whereas the nerve which is going to supply the skin of the digit, the digital branch is given off in the hand only. Palmar cutaneous branch is given above the flexor retinaculum and passing superficial to retinaculum. Whereas digital branch is given off in the hand itself. Well, what is the difference? Both nerves are cutaneous nerve. Both are going to supply the skin of the lateral 3.5 of the hand. But there is a difference. The difference, I can show you with the diagram here. Let's say, once again, this is the little finger, the ring, middle index, and the thumb. And this time we are looking at the palmar aspect. In the radial nerve, we are also looking at the dorsal. This is a palmar aspect here. This is the site for the median nerve supply, lateral 3.5 of palmar aspect. Fine. But as we said, we have two different branches. When I say palmar branch, let's see, try to use some highlighter here. This palmar branch is going to supply the skin of only palm and not the fingers. It is supplying lateral 3.5 side of the palm, skin of the palm, but not the fingers. But when I say digital branch is going to supply the respective digits, the skin of the digits, palmar aspect of the digits, and also the nail beds. Remember that nail beds we said which were not supplied by the radial nerve? That's the difference. So broadly we can say that median nerve is supplying the lateral 3.5 of the palmar aspect, fine. But precisely what branches? Palmar branch is here and digital branches are here. Why this difference is important for us? Because palmar branch is coming superficial to retinaculum, and the rest of the median nerve is going deep to the retinaculum. So that is why it is important. We'll discuss that in the clinical scenario. Well, that's a discussion on the median nerve, which we need to know, from where you can fetch the answer to certain clinical questions also. Okay, guys, in case of median nerve, we usually talk about the higher median nerve injury and the lower or distal median nerve injury. If there is a proximal or higher median nerve injury, that is like injury somewhere at the level of the elbow or above, that is a higher injury. Or if the injury is below, let's say somewhere at the flexor retinaculum, that will be, let's say, a lower injury. So we basically have to consider the two broad cases here. Like injury here somewhere in this region, let's say this will be the case A. That's a higher injury of the median nerve. And the other common site here is this case B, that is, let's say, at the level of flexor retinaculum. We all know about the carpal tunnel syndrome. That could be this case B here. So our focus here is at this point and at this point here, the higher injury and the lower injury. Again, let us discuss it first and then we'll write about it. Now, whether it is case A or case B, now let's go with something common between the two. Whether it is case A or case B, the muscles of hand are involved in both the cases. The thenar muscles will be involved in case B also, in case A also. And one of the very, very important thenar muscle was opponens pollicis. We discussed this earlier also, guys, that if there is injury to median nerve, the opponens pollicis muscle will be affected. And if opponens pollicis muscle will make the thumb opposed like this. It will make the thumb opposed like this. So if opponens pollicis is not working, your thumb will be externally rotated and will look like an ape thumb. So ape thumb is because of injury to the opponens pollicis muscle, and that is because of the median nerve injury, and doesn't matter where the median nerve injury is, anywhere it is, it will lead to the ape thumb deformity. So the point is, if I am your patient and if I come to you with median nerve injury, I definitely will come with the ape thumb deformity, whether the injury is higher, in the middle or lower part, wherever it is. So one, the common thing is ape thumb. So let's take it this way. Let's talk about case A first, guys. If I come to you as a median nerve injury, the first thing which I show you is ape thumb. Now you will see, okay, this man is having an ape thumb deformity, so that means it is having a median nerve injury here. But is it a higher median nerve injury or is it a lower median nerve injury? We still have to decide that. Now, what is the next thing you will ask me to do? You will ask me to make a fist. You will say, okay, make a fist. Now, to make a fist, obviously, I have to flex my fingers, and then only I can make a fist. And clearly, to flex the fingers, I need the finger flexors. I need flexor digitorum superficialis, and I also need flexor digitorum profundus. Then only I can flex the fingers. But if the injury is higher at this point, at so high, then which muscle is gone? FDS is also gone, and FDP is also gone. But which part of FDP is gone? Only the lateral part of FDP is gone. Only the lateral part of FDP is gone, not the medial side. You getting my point? Flexor digitorum superficialis is completely involved. Okay. Flexor digitorum profundus, the lateral half of the flexor digitorum profundus is involved, right? In that case, that means the medial side of flexor digitorum profundus is still working. If the medial side of flexor digitorum profundus is still working, that means you can still flex the medial side of finger. Guys, although all the 4 FDS is gone, flexor digitorum superficialis for all the fingers are gone. So leave the FDS part. But if you think about FDP, flexor digitorum profundus, at least your medial side of flexor digitorum profundus is working because that is supplied by ulnar nerve. So when you try to make a fist, you can actually make a weak fist using the flexor digitorum profundus finger and flexing all these fingers, but which one will not be flexed? The index finger will not be flexed, because for this finger, the FDS as well as the FDP, both are gone. So while making a fist, what will happen? While making a fist, your finger will come into this position, and that is what you call as a pointing index finger. And please be very careful about it. When I say pointing index finger, this pointing index finger is while you make a fist. It's not that the patient will come to you with a pointing index finger only. No. If a patient comes to you with a pointing index finger, that means it is some kind of claw hand. It's kind of ulnar claw hand. That's a different anomaly. The hand is fine. You ask the patient to make a fist. While making a fist, if index finger is pointing and the rest of the fingers are flexed, then it is a case of higher median nerve injury. So ape thumb deformity, which is definitely there because opponens pollicis is gone, along with the pointing index finger while making a fist, is an indication of higher median nerve injury. If it is a case of lower median nerve injury, let's say case B is there, if it is a case of like carpal tunnel syndrome. Now again, let's say if I am your patient, I come to you, I say, you see ape thumb deformity is there, so okay, there is a median nerve injury. You ask me to make a fist, and let's say if I'm able to make a fist. If I'm able to make a fist despite of having a ape thumb deformity, that means my median nerve is in the proximal part is not involved. That means my FDS and FDP are working. And just to confirm it is a carpal tunnel syndrome, there are many tests also. We don't have to go into that. That's a part of orthopedics. One simple thing that you can do is you can just check the sensation on the palm and on the finger. If the sensation on the palm is intact and lost on digit, it is definitely carpal tunnel syndrome. Why? Because look at this picture here. If the nerve is compressed here at this point, then your which branch will be involved? The digital branch will be involved. But which branch will be spared? The one which is coming above the retinaculum. So because palmar cutaneous branch is not affected and only digital branch is affected, so sensory loss will be seen in the hand, but only where? On the fingers, not in the palm. Which is also a kind of confirmation for what kind of injury is that? That could be a carpal tunnel syndrome. That means the palmar cutaneous branch is spared, but digital branch is involved because the compression of the nerve is somewhere here. If the compression would have been higher, both would have been involved in that case. Let's write about the case A and case B. The case A here, which we said is the higher injury. It's the higher median nerve injury. Now, higher median nerve injury, like if I take some cases, what could be the reason? Sometimes median nerve can be compressed between the two heads of the pronator teres. So we call it pronator teres syndrome. There is a pronator teres syndrome or cubital fossa syndrome, you can say, because it is in the cubital fossa. So there could be a cubital fossa syndrome. Cubital fossa syndrome, guys, not cubital tunnel syndrome. That's a different thing. Cubital fossa syndrome is higher median nerve injury. Cubital fossa syndrome, not cubital tunnel. Cubital tunnel syndrome is for ulnar nerve. We will come to that. What else could be the reason? Like supracondylar fracture. If there is a supracondylar fracture, that can also lead to the involvement of median nerve. Or there is another syndrome that you should know about called as a Struthers syndrome. Struthers syndrome can also lead to the higher injury to the median nerve. Now, what is Struthers syndrome, guys? For the Struthers syndrome, you should know what is Struthers ligament. If you look at the humerus, the lower end of the humerus, let's say this is the lower end of the humerus, we have the capitulum here, this is a trochlea, that's a medial epicondyle. So basically you're looking at the lower end of the humerus. Now sometime what you might see, that you might see a bony spicule coming from the medial side of the humerus like this. That's a bony spicule. And from this bony spicule, a ligament will be seen extending till the medial epicondyle in this manner. This ligament here is called as a Struthers ligament. Not always present. This is Struthers ligament. If it is not always present, that means it is some remnant of something else. This Struthers ligament is also called as the third head of coracobrachialis. It is also called as third head of coracobrachialis. Coracobrachialis muscle in human, it originates from coracoid process and inserts on the medial side of arm. That's the extent of the coracobrachialis muscle. But you might see, like in lower animals, coracobrachialis is a more evolved muscle, I should say. That coracobrachialis muscle extension is even further down. So in human, you might see the remnant of that part of coracobrachialis in the lower part. We call it Struthers ligament. It is basically the remnant of the coracobrachialis, also called as the third head of coracobrachialis. That ligament is called as Struthers ligament. And sometime what happens is that median nerve and the brachial artery, they will be seen passing deep to the Struthers ligament. That is median nerve here. This one is median nerve, and the brachial artery, they are seen passing deep to it, and that fibrosis of this ligament can lead to the involvement of the median nerve and brachial artery. So Struthers syndrome is involvement of median nerve deep to the Struthers ligament. It can also lead to the involvement of brachial artery also. So pronator teres syndrome, cubital fossa syndrome, supracondylar fracture, Struthers syndrome, there could be many reasons for the involvement of the higher injury, or can say which can lead to the higher injury of the median nerve. What will it lead to, guys? What we said here is that the common thing to be noted, whether it is higher injury or lower injury, is that opponent's pollicis, the opponent's pollicis is involved. Now that is inevitable, that will be involved. Opponent's pollicis is involved, and that will lead to what? That will lead to the ape thumb deformity. That will lead to the ape thumb deformity, which is there in whether it is higher injury or lower injury. So we cannot escape that. What is important to be noted here, that in higher injury, the FDS and lateral half of FDP, FDS and lateral half of FDP is also involved. Is also involved, and that will lead to the what? That will lead to the pointing index finger. But as I said, you have to be very careful about this pointing index finger, because when we say pointing index finger, it is while making fist. The pointing index finger while making fist. And obviously there will be a sensory loss on the lateral 3.5 completely overall. Don't have to mention that. So that's the main thing that you will see in the higher median nerve injury here. How to differentiate this with the lower injury? The case B. Case B, the lower injury, and that usually is the case of the carpal tunnel syndrome. Carpal tunnel syndrome, the lower injury. Carpal tunnel syndrome. In the carpal tunnel syndrome, once again, ape thumb deformity will be there. Can't escape that. There will be this ape thumb deformity. This time, FDS and FDP are intact, both are working. And because FDS, FDP are working, so there is no pointing index finger. There is no pointing index finger. So what is the main point here for the differentiation? And that is that the palmar cutaneous branch, the palmar branch or palmar cutaneous branch, same thing guys, palmar branch or palmar cutaneous branch is spared. So that is the main point in here, that palmar cutaneous branch is spared, and that is why sensory loss is present only on lateral 3.5 fingers and not on palm. There is no sensory loss present on the palmar aspect. Only fingers will have the sensory loss, because the digital branch will be involved, but the palmar branch or palmar cutaneous branch will be spared in case of the injury at the level of carpal tunnel. So this is about the higher injury and the lower injury of the median nerve.